Welcome to today's episode of the Neurology Video Journal Club. Today we'll be talking about a paper that was just recently published called The Association Between Frequency of Social Contact and Brain Atrophy in Community-Dwelling Older People Without Dementia, a JPSC-AD study. I am Danielle Sandsmark. I am an associate professor of neurology and neurocritical care at the University of Pennsylvania in Philadelphia. I primarily work in traumatic brain injury, which is being increasingly linked with later life cognitive decline and dementia, and have a particular interest in social determinants of health, which is why I was interested in discussing this paper and looking through the results. And I will let Dr. Magee, my co-discussant, introduce himself as well.
Hi, everyone. Nice to meet you. My name is Rogan Magee. I'm a PGY3 in the neurology residency here at Penn. I'm planning to go into cognitive neurology in the future. I completed my PhD on the study of non-coding RNA, and I'm hoping to continue that study, but applying it to prodromal biomarkers for dementias, starting with frontotemporal dementia. So I was also particularly interested in getting at some of the potentially preventative risk factors for dementia, and really enjoyed this paper. So excited to discuss it with you all today.
Thanks, Rogan, for agreeing to be with me today and going through this process. We've had fun looking through this and hope to share some of what we've learned in this process with all of you. So, Rogan, how about you lead us in and tell us a little bit more about the background and motivation behind this particular study?
Absolutely. I'd be happy to. So in this paper, Hirabayashi et al. Sought to expand on prior evidence that social isolation itself represents a risk factor for disease. Some prior evidence shows that social isolation, for example, is associated with increased risk of coronary artery disease and with stroke. So here in this paper, the authors evaluated the links between social isolation and reduced brain volume. So just to say it, social isolation represents a significant public health risk factor, as an estimated 1/4 of US adults who are over the age of 65 are actually considered socially isolated. The goals of the present work included first to examine the association between social isolation and total and regional brain volumes, and second, to determine the extent to which depression mediated those associations. So in completing these goals, Hirabayashi et al. Sought to explore whether social isolation results in atrophy that may contribute to cognitive impairment. As motivation for that hypothesis, the authors call attention to a recent meta-analysis of 51 studies. This reported an association between low levels of social isolation and higher levels of late-life cognitive function. They also cite another meta-analysis that found that having poor social supports and a poor social network increased the relative risk for clinical diagnosis of dementia. Further, they discuss two recent excellent neurology articles. If you haven't read them yet, I would jump in the references section of this paper and take a look at both of them. They're fantastic. The first is a retrospective cohort study that found an association between loneliness and both 10-year dementia risk and decreased total brain volume. The second is a large UK biobank cohort analysis that found that social isolation actually increased the relative risk of dementia, and this was independent of depression and loneliness. They also found that social isolation associated with decreased brain volumes. Importantly, that same study concurrently found that loneliness itself conferred an increased risk of dementia, but that effect was mediated by depression. Finally, as more background, Hirabayashi et al. Cite a systematic review of 51 studies, which found that poor social support structures associated with depression. And they also cite a more recent narrative review that discusses prior observations around increased white matter burden and increased regional atrophy as associated with late-life depression. So collectively, this extensive background establishes the context for the author's working model and hypothesis as pictured here on the slide. They hypothesized that social isolation may associate with brain structural changes in a manner that is independent from depression.
So determining the individual effects of these environmental conditions or socioeconomic determinants of health and how those contribute to health outcomes and disease can be really challenging. to sort of parse out all those effects. Can you discuss the methods that the authors used to try to get at this question?
Definitely. These types of epidemiologic studies need to be well designed and need to use robust methods. And I do believe that's what occurred in this study. It was a really fantastic work. So these authors worked with data from the Japan Prospective Studies Collaboration for Aging and Dementia, or the JPSC-AD. Say that 5 times fast. This is a well-established, ongoing study of risk factors for dementia, which has a current total enrollment exceeding 11,957 individuals. From a 2020 methods paper, the study group explained the purpose of the project as, and I quote here, "The burden of dementia is growing rapidly and has become a medical and social problem in Japan. Prospective cohort studies have been considered an effective methodology to clarify the risk factors and the etiology of dementia. We aim to perform a large-scale dementia cohort study to elucidate environmental and genetic risk factors for dementia, as well as their interaction." So looking again at this study, the JPSC-AD is an 8-site prospective cohort study of adults who are over the age of 65, who will be followed for 5 years. And we include the map here on the slide to show you those 8 sites. The study collects exposure data and objective metrics of systemic and brain health, which include 3D T1 MRI and blood tests like total cholesterol. In this study, depression was assessed on the 15-point geriatric depression scale, with a greater than or equal to 5 score considered to be a positive screen. So primary outcomes of the JPSC-AD include dementia, and roughly 9% of individuals were actually diagnosed with dementia by the year 2020, and also the subtypes of dementia. So 2/3 of those 9% have been diagnosed with Alzheimer's. Diagnoses in the study are made on the basis of DSM-3 criteria, and they're made by committee. So in the current work, that's the focus of our journal club here, the authors analyzed data from the JPSC-AD in a cross-sectional design. 8,896 individuals from that original study satisfy their inclusion criteria here. They had MRI data, they lacked dementia diagnoses, and they had the relevant survey answers around social isolation. These authors collected demographic information and survey responses to a question regarding the frequency of social contact, and they phrased it as pictured here in green on the slide. They wrote, "How often are you in contact with relatives and friends who do not live with you?" And they give some examples in the original work. They say, for example, meeting or talking on the phone. They considered this screening question a direct and relatively accurate categorical measure of social isolation. And their possible answers included every day, several times a week, several times a month, and seldom. Importantly, to state it, this question does not distinguish between social activity in person or by telephone, and the survey does not assess the subjective feeling of loneliness. So these authors paired the data from that question with information on potentially relevant comorbidities, for example, smoking status, cholesterol levels, and they also paired it with mini-mental status exam and geriatric depression scale scores. To assess brain volumes, they used FreeSurfer, which is an example from that software is pictured on the slide here. FreeSurfer is an open source imaging analysis software that allows for the assessment of neuroimaging data from cross-sectional and longitudinal studies. They use the tool to delineate cortical areas and to measure cortical volumes as a percentage of intracranial volume, which is a very elegant control for the individual variability in head size. They also measured white matter abnormality burden. They measured volumes in specific lobes as another step, for example, frontal, parietal, temporal, and occipital. And they also measured volumes in specific regions of the brain, like the insula, the cingulum, the hippocampus, the amygdala, and the subcortex, which was a total volume of the thalamus, caudate, putamen, nucleus accumbens, and the globus pallidi. So quite a little bit of a breakdown of the brain into the individual regions that are differentially functional, as we know as neurologists. And to state it again, they used a previously verified process within FreeSurfer to discover white matter hypointensities. And they used that process to collectively measure the white matter lesion volume. All volumes calculated by Free Surfer were independently verified through human observation to 100% ensure their accuracy. For statistical analysis, or the real meat of the work, trends among continuous risk factors by social isolation response were assessed with linear regression, and the frequencies of categorical risk factors, for example, smoking or not, by social isolation response were also assessed with logistic regression. The trends between social isolation answers and brain volumes were tested using multiple linear regression. And the authors actually used several multivariable adjusted models to do the work. They first built a model with age and sex alone, model number 1. They then added categorical and continuous, potentially comorbid risk factors into model 2. And finally, they added mini mental status exam scores into model 3. To really robustly determine whether depression, which again has been cited as directly affecting cortical volumes within prior work that we discussed before, to really assess whether depression was mediating some of their observed effects here, they performed a mediation analysis. Mediation uses successive regression models to determine the degree to which a significant prediction of, for example, as we show here, a prediction of y on x might be influenced by a separate variable m. And in mediation analysis, that separate variable m is also predicted on x. So mediation examines the strength of an indirect effect on the dependent variable by first regressing y on x, then regressing m on x, and finally examining how much the effect of x on y differs in a model that also includes m. So here, these authors point out that their total effect in this study is considered the effect of social contact on brain volumes. They consider their direct effect to be social contact's influence on brain volumes in a model that also includes depression. And finally, that indirect effect, the most important measure for mediation, they consider that to be the effect of social contact on brain volumes that is mediated or partially driven or explained by depression itself. So these are really some robust methods that produced, I would say, striking findings. Dr. Sandsmark, would you mind walking us through these results?
Yeah, thanks for that excellent background, Rogan, and really setting up the background and a lot of work that's gone into kind of getting us to this point to be able to think about how depression or depressive symptoms might interplay with frequency of social contact and brain volumes. So when they went to look at these data, they found that of these nearly 12,000 individuals that were enrolled in the study, about 8,900, 8,896 to be precise, individuals had all the necessary available data, including the survey response that you mentioned, as well as Free Surfer quality MRI scans. So T1 weighted images that could be fed into the system and analyzed in a robust way. So table 1 shows a distribution of the demographic factors of the individuals included in the study, subdivided by their frequency of social contact. So individuals who had a lower frequency of social contact in this seldom column here were more likely to be male, had lower educational attainment, and were less likely to be employed. They were also, perhaps not surprisingly, less likely to be married and more likely to live alone than those who reported having more frequent social contact. Interestingly, those with few social interactions were also more likely to have certain vascular risk factors like hypertension, diabetes, smoking and alcohol habits, and prior history of stroke and heart disease. They also, interestingly, also had lower cholesterol levels, which is somewhat in contrast to some of the other vascular risk factors that they had. Interestingly, they also had lower scores on the mini mental state examination and were more likely to report depressive symptoms. So with this as kind of a background of the cohort that was studied, the investigators then used these demographic factors in building the models that they used to assess brain volumes across this population. So, as you already mentioned, in their initial model, they controlled just for age and sex and looked at the impact of those demographic factors on brain volumes. In a second model, they included some of these other health factors. So they looked at both educational status, occupation, or employment status, their living situation, and then also vascular risk factors were included in that second model. Finally, in the third model, they included the MMSE as a marker of cognitive function to determine how adding that variable into the model impacted overall brain volumes. So this figure really kind of shows the meat of this paper, where they looked at total brain volume as a percentage of the intracranial volume. So this gets at that point that you were mentioning of using each individual's intracranial volume and then looking at the proportion that is occupied by the brain parenchyma itself. And they looked both at total brain volume as shown in panel A, and also white matter lesion volume as a proportion of intracranial volume in panel B. Interestingly, the authors found that total brain volume decreased as social isolation or lack of social isolation increased. So those with very infrequent social contacts had lower total brain volume. And that was true across these models. So, in model 2, where we adjust for educational attainment, occupational status, and some of these vascular risk factors, that did decrease the difference a little bit. It was still significantly different compared to those who had more frequent social contact. Similarly, when you add in the mini mental state examination, there was really a minimal effect of adding that into the model. So again, suggesting that this change in, or this decrease in frequency of interaction was associated with a change in total brain volume. They found similar, although less visually dramatic, results when you looked at total white matter lesion hypointensity. And similarly, there was an increase in the number of white matter lesions in those who had infrequent social contact. So again, suggesting that lack of social contact does impact what we think of as having a healthy brain. So bigger volumes and lower degree of white matter abnormalities. They then looked at this in a regional way and assessed regional brain volumes. And they found that, again, that a lower frequency of social contact was associated with smaller volumes in regions specifically linked to memory and social cognition, including the temporal and occipital lobes, as well as the cingulum, hippocampus, and amygdala. In the supplemental figures, they also showed that when they further subdivided these regions, they saw volume changes in the subregions of the temporal and occipital lobes, as well as the cingulum. So again, getting at your point that they really took a deep dive using this free surfer analysis method to look at these individual regions in a way that really hasn't been done before in some of the prior work in this area. I will point out that these authors also performed a sensitivity analysis. So they repeated these analyses where they eliminated about 1,500, a little over 1,500 patients who were diagnosed with mild cognitive impairment. And when they excluded those individuals, that did not significantly affect these results. So when you get rid of those individuals who had sort of the poorest cognitive performance, you still see a relationship between brain volumes and the frequency of social contact. So that adds some weight and some significance to their findings. And I think it's to their credit that they took the effort to do that separate analysis. Now, getting back to what you were mentioning and described really well for us about the mediation analysis, they performed this series of regressions, have the model up here to refer back to determine the mediating effect of depressive symptoms on the relationship between the frequency of social contact and brain volumes. And what they found looking at this indirect effect was that total brain volume was mediated by these depressive symptoms. That explained about 15% of, or contributed to about 15% of the difference that was seen. And that mediating effect was also regional. And so you saw it varied across regions of the brain. So it explained about 17% of the difference in the amygdala, whereas in the occipital lobe, the indirect effect of depression or depressive symptoms explained about 29% of the volume variation. So I think this analysis and the sort of the way that they broke this apart and added in this mediation analysis really strengthened what we can glean from this paper. So it might be helpful if you can kind of summarize kind of these findings and distill them down, and we can have a discussion about the kind of implications of this study for clinical practice.
Sure. Thank you very much for walking us through those results. As you mentioned earlier, it can be very difficult to perform these types of large-scale epidemiologic studies. So I think as you emphasized, the authors did their very best to try to use robust statistical methods to answer their original question. And so I guess in summary, their findings suggest that a lower frequency of social contact is significantly associated with decreased brain volume in regions that are linked to cognitive function and therefore to dementia risk. And they found that this association existed only in a manner partly mediated by depression. That 15% is quite a small number in terms of mediation analysis. So suggesting that social isolation or the degree of it itself was more so responsible. Their findings join a variety of prior observations. One observation is that loneliness is associated with lower total volumes and a higher white matter lesion burden. And another observation is that social support is associated with a higher total volume at baseline, those being from the Framingham and Rotterdam studies, respectively. As we chatted about earlier, the only other really large population-based study of its kind, the Neurology article focusing on the UK Biobank, also robustly assessed social contact. And in that study, the authors found that there was a lower gray matter volume in regions also associated with dementia risk. So again, this paper is joining a lot of emerging, growing collective evidence that social isolation actually does associate with smaller brain volumes in areas that are linked to cognitive impairment.
Yeah, I think that's a excellent assessment and summary of the findings. I think it's really important that, as you mentioned earlier, we really, in this study, were able to get into these regional differences, particularly in single center or few center studies. Interestingly, I think that the brain regions implicated in this study, particularly the hippocampus and medial temporal lobe, have been previously implicated as sort of early changes in Alzheimer's disease. And also the amygdala has been associated with social isolation. So by starting to address some of these regional differences, I think this study really expands on our prior knowledge gleaned from these larger observational studies and allows us to kind of get at, that this may be an earlier event than we maybe knew before.
Definitely agreed. And I think another important piece of discussion that the authors actually include themselves is to call attention to similar prior observations of what I guess we could consider to be adjacent neuropsychiatric phenomena, being depression. Social isolation, depression, and loneliness might all exist kind of in an overlapping realm, but The authors here bring attention to prior observations that late life depression actually associates with low volumes of cingulate, temporal lobe, hippocampus, and amygdala, like they found here. But they point to their mediation analysis, and they reason that their findings imply that the effects on brain volumes that they observed are driven in part by another mechanism. And given that they found significant trends with other potentially systemic comorbid risk factors, they raise up those factors themselves as potentially explanatory. They include smoking, physical inactivity, hypertension, and diabetes in their discussion, arguing that potentially those are driving some of this interplay, because all of those factors had significant trends across social isolation as summarized in Table 1.
Yeah, I think that's going to be a really, interesting area as, and a focus as we try to, practice preventative care in these diseases. I think also another thing that I really liked in this study was including the MMSE scores in their multivariate adjusted Model 3 and using the sensitivity analysis, as I mentioned earlier. I think it's always a question of what is the impact of cognitive decline itself on the frequency of social contact. And so, as I mentioned earlier, I think that by repeating this analysis, eliminating those with significant cognitive decline in the analysis, and still seeing that these associations hold, really strengthens the assumptions of the model and supports the underlying hypothesis, and that suggests that this is something that we should be really paying attention to. That being said, the authors do recognize the relationship between social contact and brain atrophy, that there may be some bidirectionality here, and perhaps setting up something of a vicious cycle, where whether social isolation begets cognitive decline or begets depression, or the other way around. I think future studies will need to address that in different ways and parse it out. But I think this is a good first step, and suggests that interventions that can target reduction in social isolation, while they may not be the be all end all, they could perhaps provide some prevention of continued atrophy and dementia risk. As with any study, we should talk about some of the limitations and some of the strengths of this study, which I think we've highlighted a little bit already. Are there some things that you think that we should think about in terms of the limitations of this study and how it might impact our clinical practice?
Definitely agreed. Always important to look at limitations and weigh those when deciding whether or not to take something to the clinic. Just to sort of summarize them again, I think the strengths of the study are the large sample size, that mediation analysis and the sensitivity analysis, as you described, and their just general treatment of several possible confounds. Some of the limitations are that this was done within a single geographic region. So I think future large population studies in other regions will clarify the generalizability, because again, this was working solely in a Japanese population. So perhaps repeat studies in Europe or the US might add some clarity. Important to note, I think, as we think about this moving forward and as we kind of carry the pearls away from this conversation, the study was cross-sectional, so we can't really speak about causation, cause and effect. We have to speak only about association. But one of the biggest kind of takeaways for me is that the authors call attention to a prior observation that the subjective feeling or the subjective reporting of loneliness by individuals may actually also have mediated their primary outcomes, including cognitive impairment and volume changes. Unfortunately, they did not collect information on loneliness, so I'd consider that a significant limitation, but one we can chat more about.
Yeah, I think this concept of social isolation versus loneliness is really interesting to think about, particularly as we think about assessing our patients in a clinical setting, and perhaps asking just the the standalone question of, how often do you interact with others? I think that also assessing, do people actually feel lonely, regardless of that frequency of social contact, is an interesting one to think about. And, is perhaps something that is more easily kind of addressed with a patient in the clinic who and can talk to, versus in this study setting where you have to kind of weigh your how many questions you're asking research participants and how much you can really get from them in kind of a standardized way. So I think that's it's a really important idea to bring up, that social isolation may not equal loneliness, and often does not equal loneliness.
And I think kind of the way that I might think about it for me specifically is perhaps social isolation is a quantitative measure of your exposure to other individuals, and loneliness is that qualitative measure. It's what is the real effect on you of your degree of interaction. And I think that they do overlap quite a bit, but perhaps the extent to which social isolation actually results in loneliness might not be a linear relationship. It might be pretty complex. It might depend on personality traits like resilience and your degree of extroversion. I think it's a very, very important concept to continue to think about as we, again, like you say, as we study this more, but also as we bring it to clinic. And I think, once again, future studies will provide clarity.
Yeah, always the case, right? I think your point about this, being isolated to a Japanese cohort, is important. I would just echo back what you already told us, though, about the Framingham and Rotterdam studies that, although not exactly repeating this analysis or, they're not mirror images of one another, but they do kind of suggest trends in the same direction where, loneliness or social isolation, depending on the mechanism by which it has been assessed, those studies in, large US cohorts or multinational cohorts have found some similar results. So, I think that's that background there is particularly important when interpreting this, on its surface, a kind of a more isolated or demographically homogeneous population.
Definitely agreed. So I think thinking about all of this, how would you move on from here? How would you incorporate this into your day-to-day, perhaps?
Yeah, I think that, I think we're seeing more and more that these social determinants of health, and I think we don't often think about social isolation, or at least I didn't before reading this paper. I thought much more about socioeconomic burdens, financial stress, frailty kind of measures as kind of thinking about those as social determinants of health. But I think this really has moved to the forefront of my mind that that this is one of those social determinants of health that we could screen for more routinely in a relatively easy and sort of non-invasive or non-prying way with our patients. I think that we're getting better about screening for social determinants of health, or at least that's been my experience. But we recently looked at the literature on this, and some studies looking at EMR data where you get these kind of prompts to screen for social determinants of health, they found that only about 2% of patients were being screened in this way. And so, this study, for me, thinking about this, in a patient's room, just kind of perks, when I hear these things that make me concerned about, the level of engagement that somebody has, or their sort of cognitive load and kind of what kinds of interactions they're having. This will definitely perk my ears to kind of pay attention to that. And, perhaps add some of that, those reminders to my counseling.
I couldn't agree more. I think we could do well to bring that 2% number up. And kind of what you're suggesting is that with just a single question, you might be able to make a huge impact on a person's life and quality of life moving forward. So I think this is an important question to ask. And I really enjoyed reading the paper, and I really enjoyed discussing it with you. Yeah,
thanks so much for joining me in this discussion. I think it'll be really interesting how this work develops, over our careers, and particularly in your chosen field, in cognitive neurology. I think seeing how some of this unfolds as we have, new both research methods and treatment options. I think it's going to be an exciting area for intervention. Thank you all for joining with us today. I hope this discussion was helpful, and look forward to reading more about this in the future. Take care.